Well, good morning, everybody. Actually, it's afternoon now. So welcome to the uh, forum with the North Carolina Serious Illness Coalition Clinical Practice Working Group. We have a very special group of folks joining us today to talk about some really important issues that relate to clinical practice. And I'm just going to mention, I'm David Sevier, by the way, one of the co-founders of our clinical practice, our North Carolina Serious Illness Coalition. And I'll just mention that the coalition is about 10 months old. We came out of the North Carolina Institute of Medicine task force on serious illness care. And one of the recommendations to get a coalition put together came out of that task force. And so we have 135 members now representing 75 different organizations across North Carolina. And we're very excited about all of the great work that's going on. So welcome to this forum. This is the first in a series of forums that the clinical practice working group is putting together, and we have our co-chair Christopher Morissette is going to introduce our topic for today and our moderator. So Chris, go for it.
Good. Thank you, David, and thank you all for joining. And very excited for you to be a part of this. We're calling a brown bag series. Idea is it's going to be over the lunch hour. Bring your lunch and have the opportunity to engage and learn. I do see Laura Patel, my co-facilitator of the clinical quality work group. And we're so excited. We really felt like having a series of forums to really discuss quality, analytics, data, and how do we truly, within North Carolina and beyond, begin to move serious illness care forward in both access to care as well as aligning around clinical quality. And proud today to introduce a friend of mine, Dr. Arif Kamal, who will be our moderator. And he, as many know, has worn multiple hats, but really has been a champion of clinical quality throughout serious illness care, being involved in various organizations, as well as here locally at Duke as a physician and a professor. And so excited to have Arif moderate this series for us today. And Arif, I will turn it over to you. And again, thank you all for joining. Arif's going to share details on our next forum, which will be coming up here in January. Arif?
Awesome. Well, thanks, Chris, and thanks everyone for joining us. As we really appreciate an opportunity to sort of just kind of have a very informal conversation about sort of advanced analytics and serious illness care. And I'll tell you, I'm sort of facilitating this conversation for very selfish reasons too, because I want to learn a ton about what people know about this space, and in particular, really understand how we can apply these techniques to serious illness care today. So I'm going to start just with a few slides just to sort of set up the conversation that we're going to have. And I want to give you just a little bit of background here. So again, my job is just to facilitate a conversation. I'm going to do very little talking, actually, and we'll let our speakers do most of the talking, and we'll talk about some of the themes and stuff that we have. Here's the disclosures. I think it's important to recognize I do have a relationship with Acclivity Health, but I'm going to stay out of the conversation other than to ask the questions that have been put forward by all the different speakers, and we'll go in a particular order with themes that I'll talk about. Just in terms of resources for the conversation that we're going to have, I think there's a couple important places to start, and I hope many are familiar with these. If they're not, these are great links for you to take a gander at while people are talking. The first is from the National Coalition for Hospice and Palliative Care. And as many of you may know, they recently completed the 4th National Consensus Project to identify quality measures and guidelines for palliative care delivery. And that's a free document put together by a lot of national experts. And I think is really the floor, not the ceiling, for the discussion of quality of care delivery in serious illness and palliative care. So I encourage you to go there. Second is the recent formation of the Palliative Care Quality Collaborative, which is the first unified registry initiative for quality measurement in the field of hospice and palliative medicine. This is a conglomeration of efforts from the American Academy of Hospice and Palliative Medicine, the Global Palliative Care Quality Alliance, the Palliative Care Quality Network. and CAPC, the Center of Advanced Palliative Care, and the National Palliative Care Research Center. And so I encourage you to take a look there at the registry offerings that they're providing. And then lastly, my interest is in burnout and resilience, and I can't help but say I think we should all take a moment to work on our own resilience building. And so at Duke, we built a very simple web-based app called The 3 Good Things. It's based on a lot of good work out of Duke and Marty Seligman in the positive psychology world. As I mentioned, it's a free app to journal 3 good things every night and to share that with your own private circle of friends or family that you can dictate. So I encourage you to take a look at that. So our objectives today are really quite simple, actually. We're going to use a rapid format with people to kind of weigh in the conversation to first start talking about how do we get sort of a working knowledge or a walking around knowledge of advanced analytic terminology. I think there's a lot of different terms that are used and they can be confusing and overwhelming. And I think it's important for all of you that are clinicians, administrators to sort of walk away from this hour saying, okay, I kind of get the basics of it and know how to sort of talk with other colleagues about it too. Second is to really talk about what are the use cases for the benefits for patients and caregivers to use advanced analytic techniques, particularly answering the question, well, we've been doing hospice and palliative medicine for decades without these techniques. So why now? Why this? Why is this thing? Is this a flash in the pan? Is it going to go away? So I think it's important to recognize what have we learned about potential benefits. And then lastly, we want to understand what can this bring to providers and practices, health systems, and payers. We know that there's a lot of shifts changing, a lot of winds churning in different directions in our world. Palliative care and serious illness care has become very much of a hot topic and very popular. And so because of that, it'll be interesting to hear from our speakers sort of how does this fit into everything else that's happening as well. So the format for today, and then this is going to be the last slide, is just we're going to spend about 45 minutes in a conversation style discussion with our speakers, which I'll let them introduce themselves here in a minute. Then we'll have 10 minutes for audience Q&A at the end. What I'm going to ask you to do is we don't have a chat function. So what I'm going to ask you to do is hold your questions till the end. And then when we're at the end, I'm just going to ask you to raise your hand and we'll call on you individually and then let you speak. Right now, you are all muted, and then we'll unmute you for that section. So all of the speakers and planning organizers put together a list of questions that fall within 4 themes. The first one is the basics of advanced analytics, which is where we'll start. Then we'll move forward to applications to serious illness care. So you'll see we'll dive deep into sort of the general applications into serious illness care applications, then benefits to patients and caregivers. And lastly, why to incorporate such techniques today? What actually is the imperative, if at all, to do this kind of work soon? So with that, I'm going to stop. I'm going to stop sharing my video and we'll get to the conversation. So I'd like at first, I think Len and Caitlin to introduce yourselves from the Cyft team, and then we'll move to the Acclivity team. Len, do you want to go first?
Yeah, happy to. Can you hear me all right?
We can.
Great. So first, thank you for the invitation. It's an honor and a pleasure to get to talk to everyone. My name is Len DeVolio. I am the CEO and founder of Cyft, an advanced analytics company focused on serious illness care. I'm an assistant professor at Harvard Medical School and Brigham and Women's Hospital.
Hi, everyone. Good afternoon. I'm Caitlin Brennan. I'm the VP of Clinical Improvement at Cyft. I'm an oncology nurse by training, and I'm a practicing palliative care nurse practitioner. I also have a PhD in nursing and an academic affiliation with Boston College. And I'm just really delighted to be a part of your first clinical practice forum today and looking forward to the discussion.
Great. Thanks to you both. Jeremy and John?
Thanks, Arif. So Jeremy Powell, CEO and founder of Acclivity Health Solutions. We are a workflow company that actually takes analytics and makes the insights actionable at the point of care. I'm actually very pleased to be working with North Carolina Serious Illness Coalition. It's interesting, our little business employs about 1/3 of its current employees out of the state of North Carolina, so lots to do today in hopes of having furthering opportunities for us to work together, all of us together in the future in some meaningful way.
Yeah, thanks for inviting me. My name is John Mulder. I'm a palliative physician. I've been doing this work for somewhere around 35 years. I am the director of the Division of Palliative Medicine at Michigan State University College of Human Medicine. I run our fellowship program up here, do a lot of consulting in hospice and palliative medicine for a large elder care company called Holland Home out of Grand Rapids, Michigan, where I work and I serve on the board of Acclivity, which is my connection with them.
Great. Well, thanks to everybody. So, all right. So we're going to start on the basics of advanced analytics. So not to fear, we're going to get in on sort of the basics of this. And so I'm going to start. Maybe Len, I'll start with you, and we'll just kind of work through the group. So I'll tell you, I've heard lots of terms, right? So we hear about advanced analytics, machine learning, artificial intelligence, actionable insights, natural language processing. Can you help us have sort of a basic kind of working understanding of what these terms mean, and in particular, which of them sort of apply to what we do in serious illness care?
Sure. Well, they're often used interchangeably, which I think creates part of the challenge. They are different concepts, but I think what it comes down to is basically these are all techniques intended to help turn raw data into actionable insight. The best way to think about how it could be useful in healthcare and candidly how it's used in other industries is we like to use the analogy of a map, right? So we all, in the past, you're trying to get from point A to point B, you could use a paper map, or you could ask directions of someone, basically going off of their understanding of the best way to get between point A and point B. Now with advanced analytics, you know, we're still trying to get between point A and point B, but as you know from Google Maps and Waze, we now have the opportunity to bring in all sorts of data and to use math to calculate in as near real time as possible, you know, which is potentially the most effective way to get between point A and point B right now, based on where I'm trying to go and based on what's happening around me. And we like the analogy of map because it also makes clear that these technologies are not making the decision for you. You're still the driver. It's just that now we can use advanced analytics, machine learning, natural language processing to help people make decisions based on more information delivered at the right time to help support the decision. So I hope that's helpful, because I think it's too easy to mix all of these terms up and to lose perspective that it's really just about using more information to help support clinical decision making.
That's very helpful. And Jeremy, your thoughts too.
Yeah, so I agree. I think the map example is a good one. I think the emerging science around what we all do in advanced analytics is often misunderstood. I will often lead talks and ask a question to the audience. How many of you use AI or machine learning in your day-to-day lives, personally? And most people will sort of shyly raise their hands. The reality is everyone does. So Lynn gave a good example about maps, but if you're on a dating website, they're using that to predict who your matches are. If you're on social media, oftentimes if it's tied to likes, they'll figure out specifics about how those likes can tie you into other things that might be advertising or other things. So it's everywhere. What healthcare has been always sort of lacking at, in 20 years of me doing this work, is it's always sort of been late to adopt innovations. It does a great job on the clinical side. So folks like Arif and Caitlin and John understand how the emerging art and science of medicine can be deployed at the point of care. That's well known. What's missing often is the efficiencies that could have been impacted. So Arif, when we talk about advanced illness with you, someone who has a pulse or a MOLST from a Duke clinician that presents in the emergency room, there isn't a lot of trust in the fact that that form was done by somebody who I know what his medicine criteria are. So medicine sets up these boundaries to make it tough to take an innovation. What advanced analytics does, though, and why this is important, is it makes it as simple as Google Maps. It makes it as efficient as what Waze can do. And now, instead of us thinking about, I've got to change my clinical paradigm or I have to learn a new skill set, it really is augmenting what you already do really well, the high-touch part of medicine, with some high-tech things that are just so simplified on the back end for you to consume them in a way that you've never been able to before. And I think advanced analytics will eventually be as standardized as a software platform having a database. So we might feel like we're on the cutting edge of this in medicine, but the reality is it is really a long game. These analytic tools have been deployed since the 70s in some way, shape, or form. Medicine is just now ready for them to take shape. And I think you're going to see the impact of it around seriously ill patients, around the traditional spread of patients and their acuity will consistently give us grounds to deploy technologies like advanced analytics, like machine learning, like AI, and like insights that are actionable.
That's great. So Caitlin, to you, medicine's a high touch, art centered. I mean, there's science for sure too. So for us clinicians and for patients and caregivers that would worry just in healthcare in general is, do we really want machines to help us do this work? That seems scary. And so tell me it's not scary, Caitlin. Tell me it's helpful.
Not scary. We're going to put you all at ease here. And I think the idea here is that, the people who are making the decisions are still people. So the machines aren't meant to take over those determinations. And, machine learning or advanced analytics can make helpful suggestions to you that you may not have thought of as a clinician, or that will make the decision in front of you sooner than maybe you would have gotten there yourself, kind of back to that maps analogy. And again, you're the driver, you don't have to take the route that it recommends. However, it's putting in front of you, a nudge or a suggestion that combined with your clinical judgment can be more powerful than, advanced analytics or your clinical judgment on their own.
That's great. So John, I'm wondering too, so advanced analytics might give us a nudge, and then we might have our own sort of clinical intuition, right? So, just again, broadly in healthcare, how do we sort of reconcile, new information streams that may be coming at us with our sort of own inherent sense of sick versus not sick, or, needs our help versus not needs our help?
Yeah, I think there's a couple of different nuances to that. As a clinician who's been around for a long time, I grew up in a model where the physician's clinical insight is what directs the plan of care, and we didn't have a lot of, even though Jeremy's correct, we've had various aspects of data and analytics for a long time. It just was not necessarily computer based, and it was modified and interpreted in different ways. We pride ourselves in wanting to do the right thing for the right person at the right place, right time. And yet we find ourselves bound by an awful lot of constraints, not of our own making, but of systematic. There are systematic barriers that come into play there, and so we, as palliative clinicians, get frustrated. We know that the patients are out there that should be cared for in a different way. We know that clinicians want to do the right thing. They don't always know how. So part of it is an educational process, but then part of it is, how do you now use what you know as your intuition, your clinical acumen, and how do you take and now be able to expertly apply that to a particular patient population to know that we're getting the right patient into the right place at the right time. And so that's where I see the benefit of this. Again, not using the analytics just to throw more data at us, but to really help to provide some context that allows us to be able to best manage that patient and best direct the right resources to that patient when they need it. And I think that that type of a process does not infringe on my clinical judgment. What it does is it helps to enhance it. And that's what I see as a benefit to the analytics, is that it helps me to be a better provider, not by creating an algorithm that I have to follow, but by helping me to understand what all this data means. I had gone into my own, medical portal once when they were first starting to set this up for my primary care doc, and I had to call him and says, "You've got 128 problems listed on my problem list. I'm not that sick a person. So please help me understand how you're using all of this information to direct my care." And I think that's really, at the rudimentary side of EMRs, we had to sort through those sorts of, we'll use the technical term gobbledygook to really help to interpret what does this all mean. And the advanced analytics is what's going to do that. It's going to help us figure out what does this all mean. So the important things are out there, and the direction that the physician needs to help to guide are helpful to him and not just muddying the water.
That's great. So, Len, we're sort of on the sort of the topic of helpfulness, and then I think also part of this is also trust, right? Sort of trust in the data. And I'll just say, as a health services researcher, I'm used to doing, logistic regression models, and you might take a training set, and a validation data set. You kind of look to see, do your, odds ratios and so on sort of pan out. But now you're talking about, so how do we kind of validate what a model might show? What are sort of best practices in terms of doing that?
So it's not all that. I mean, first, I think just like earlier we talked about how we're using all these terms interchangeably. Another misperception is that that we don't know what it's doing, that machine learning is black box. And I think part of that has been, that fire has been fueled by a lot of talk about how it's going to change healthcare and change the world. And I think the other part is that traditionally analytics vendors, IT vendors in healthcare there's a bit of a tradition of dropping software off or installing it and saying, trust me, it works. I think it's, if you want to believe whether or not software works, you should be part of evaluating how well it does in your own population. And that is done almost the same way as you just described for logistic regression. So you shouldn't just trust that it works. This is too important. We're talking about directing care to people that are seriously ill. And so best practice is to do what you just described, to have a population of people from whom you learn, and then a population of people that you evaluate the performance of a machine learning model against, just like you would as a health services researcher for logistic regression. And similarly, we look for statistics that tell us how accurate the models are at predicting whatever it is we're attempting to predict, whether or not somebody's heading for an admission, whether or not they're nearing end of life and should have a goals of care conversation. We really want to run experiments within the data so that we can trust as clinicians that if I give you a list of 20 people that the machine believes are heading toward a preventable admission, I should know, based on experiments run hundreds of times on data that happened last week, last month, last year, how good that list is. And the statistics we use for that are not much different than what you're used to: positive predictive value, sensitivity, specificity. Good science still applies here. And I think it's really important for clinical teams to participate in that science to understand how good or bad an algorithm is. And just like in statistics also, it's important to understand if the population you're applying that math to is the same as the population where the model was built, right? A model created to identify people that are heading toward admissions that are sick with cancer may be different than if you're working in a pediatric palliative care unit. And so it's just like good statistics, it's very important to evaluate the math and to understand that the math has been designed to work with the population that you're serving.
That makes good sense. So Jeremy, I'm wondering, you guys have been at this for a couple of years, and it sounds like this is very iterative, right? You're kind of learning as you're going. So machine learning is not an endpoint, but it sounds like it's a process. Can you describe sort of a little bit about how partnerships work, where you kind of iteratively learn?
Yeah, so the points Len made, I think, are appropriate relative to how the models improve and how you might understand their efficiencies and effectiveness. What we've done as a practice all along is to build benchmarking capabilities that allow you to see the things that clinicians typically need to see. So your practice, Arif and John and everyone else that's clinical, it stems from your sense of experience in a certain population. So in your North Carolina population, you get very comfortable with recognizing oncology journeys and what's likely outcome based upon your clinical experience and training. We want to promote that exact same experience. So if a model suggests that this outcome or terminal scoring for patients' prognosis around a certain journey with oncology is fairly grim, and the model is producing that level of input, we've learned over the course of our tenure as Acclivity that is only as good as the other evidence that you can support in parallel to allow the Arifs of the world to see the things they're used to seeing in their clinical decision making. So a benchmarking of patients like that and what their outcomes laid side by side with a model that's predicted this person's outcomes are going to be a really short prognosis is the way to tackle those things, we think, because it allows the individual clinician to really see patients that are identically aligned from a comorbidity perspective, level of diagnosis, acuity, palliative performance scale, terminal scoring, et cetera, and then see them stacked up against patients just like them, same age, same demographics. And when they see the outcomes of those other patients, now it's not black box. Now it's not a trust thing that I have to, make a leap of faith to believe the model is getting it right. I can literally rely on what my acumen and training has taught me, which is that these things have happened on the same kinds of patients with these outcomes, and they match to the model. That then gives the human, it's just like you when you drive from work using the map example. If you've driven from work every time from your work office to your home, and you know the way you go typically, it's going to take something major for you to choose that model is better than you. That's the same exact thing clinicians do. And so we want to show you, hey, this is what your model shows you, and it shows you these kind of outcomes. We think this person's going to look like them, and oh, by the way, when those are aligned, there is very little disagreement. And so that's what we've done specifically to support that kind of knowledge. On our work with really big organizations, they make us do more than that. So the more often is my clinical teams who are going to react to this knowledge need to have some confidence in the model. So we show them the features. We show them which features have the most importance, whether it's the medication list, whether it's the documented problems or diagnoses, whether it's the level of severity of their acuity by intensity of services that have been applied. We get them comfortable with what we see as features and then showcase which of those features have the most prominence. And they get buy-in to that model, or they don't, and we adjust the model to their specifics. All of this is tunable, and it's tuned to Lynn's point down to the population, to what their needs are, down to the clinical teams and what their expectations are. And it allows us to be pretty accurate at meeting what their needs are. But if you do those things in combination, they trust the model, and then they trust the medicine because it's using this other way that they've always done it side by side with what the new way is.
Yeah, that's great. So Caitlin, I'm wondering, I know you guys at Cyft have a quality collaborative and you're bringing folks together. I wonder, gosh, for people who say, I've been doing this for decades and, I can help generally do good prognostication. I can get a sense of, comorbidities and performance status and other things to particularly identify patients who have serious illness and are particularly maybe eligible for some type of advanced care delivery, be it palliative care or enhanced navigation or home-based care or that kind of thing. Aren't we good enough at identifying who needs more care? I mean, we've been doing a decent job, I feel like, for some decades, and here you guys are telling me that maybe we're not. So help me reconcile that cognitive dissonance, or help me understand how we can be better at that.
Absolutely. So part of this is sort of change management 101, and the fact that as humans, we are sort of reticent to give up what we're habitually used to and or what we've been trained to do, and we are experts in our field. So all of that is completely understandable. And I think, going back to the science, we know that there's lots of evidence that we do get it wrong a fair amount. And, when we think about intuition or the surprise question, there's really good evidence that on both sides of that coin, we can be wrong. And I think we all, when we think about our clinical practice, we all can remember and think of patients recently and in the past who we thought were, say, headed for the end of life. And it turned out that they, quote unquote, bounced back, or we're surprised that someone has lived as long as they have with a number of comorbid conditions, a number of hospitalizations, and so forth. And the opposite is true as well, where we know there's good evidence as well that the more physicians and nurses know their patients, the longevity of that relationship can sometimes hinder the fact that, this person is reaching the end of life phase and we overestimate how much time they have. So I think the idea here is, to kind of stick with this theme of advanced analytics is really meant to go hand in hand with our clinical judgment. The advanced analytics part maybe takes some of the human component out for the actual prediction, so that some of our own understandable sort of blinders that get put on because we are human get sort of taken out, and the advanced analytics can do its magic. It's not really magic, but can do its thing, and can understand patterns in the data that we as humans really just cannot pull out. It's not humanly possible. And then we add the human component back in when we have to implement those predictions, and we decide how to use them at the point of care and what to do about it when we're sort of faced with a patient that has a high ranking on our predictions. And I think the other piece to remember is that this is a give and take. This is a dance that just like humans aren't perfect and we're sometimes wrong, machines won't get it right every time either. So the idea here is, can we get a little bit better? Can we use these tools, and can we measure what happens? And that measurement piece being a very important part of sort of whether it's a research process or an implementation process or quality improvement process. When you're continuously trying to improve your work and continuously trying to ensure access and equitable quality care for people with serious illness, you're making these incremental changes over time and measuring what happens. And sometimes you're going to get it right, and sometimes you're not. And the idea here is that we work together, that we don't forget about our clinical judgment, but that we're open to sort of what the data say, and to working together as a team to get it right.
Great. So John, I wonder, I feel like as you've been around for a while, so as palliative care has grown, as hospice has grown, there's these sort of mixed messages, right? Hospice wants more patients earlier, if possible. Many palliative care programs are sort of, busting at the seams in terms of being able to handle all the patients that are coming their way. So help me understand how advanced analytics isn't going to just throw a bunch of patients on my doorstep and overwhelm my clinical service tomorrow. I mean, what are the efficiencies or, identification advantages that are going to come from these types of approaches?
Well, first of all, it is going to dump a bunch of patients on your doorstep, so you need to be prepared for that. Because if this is working right, one of our presumptions, and even going into this, is that we're not getting the right patients in the right place, and people are unnecessarily suffering or getting tracked into places within the healthcare system where they don't belong. I was asked, it was just pre-COVID, so it's got to be several months now, by the geriatric hip fracture team in one of our hospital systems, if I would meet with them. And it was a large committee. There's over 30 folks in that room, who said, we've got a problem. We get these folks that come into the ER, they have hip fractures, and we fix them all. And some do well and some don't, and we don't know why. So we applied a frailty index, and turns out they're all frail. Can you help us figure out which patients are going to do well and which patients are not going to do well? And I said, yeah, actually I can, because there's a lot of good data out there that can demonstrate, based on a patient's level of comorbidities and their medical history, and there's a lot of factors, who's going to do well and who's not going to do well. And so what analytics does is it allows us to be upstream on that and be able to identify folks who do have underlying elements of serious illness. Are all of them going to require palliative care or hospice? No. That's, to me, the end game is not to say how many patients can we get into hospice or how many patients can we get into a palliative care service, but how can we best stratify these folks? I mean, we all know that the social determinants of health are a huge deal in terms of patients' morbidity. Those of us that worked in hospice know that we've seen people who are engaged in palliative and hospice services that should not be there, but because of the elements of this is what now getting beyond the scope of this, but where we see systematic institutional racism has impacted the care that people have gotten, and now they're much sicker than they should be, and needing different levels of resource. Well, if we can find these folks upstream and to be able to stratify their needs in a different way through different elements of connections, social service connections, and there's all sorts of different things that we can use to help people improve their level of health, and to even prevent some of the consequences by getting them into the right place, right time. So. I think that the goal is not to populate palliative care programs, although those of us in the field think that's not necessarily a bad thing if we can keep up with the workforce, but to make sure that we're identifying the right folks and getting them into the right environment.
That's great. So I wonder for Len and Jeremy, so when we think about what are the greatest changes that are happening in serious illness care right now, I think it really is payment reform. And there's an alphabet soup of what's going on out there, right? So you've got medical homes and MSSP, and you've got hospice carve-in for MA, and you've got the SIP program and so on. Can you just help us very simply sort of understand what's the role of advanced analytics, particularly as it relates to organizations that want to be successful and sustainable within all these payment changes that are happening? Len, I'll let you go first.
Sure. The reason we're having this conversation, the reason we're talking about advanced analytics now more than we ever have been in the past is because of the payment reform. And what it's doing is basically moving us from a model of you get paid for service provided for each unit of service provided to a model of you now need to figure out how to allocate your resources most efficiently in order to get the right care to the right people at the right time and reduce unnecessary expense. And so now, for the first time, healthcare becomes more like other industries where you have a budget with which to successfully create a product or execute a vision. This means that now, for the first time, you need to be able to use all of your data efficiently to perform well in contracts. So for example, with the PCF SIP contract, it's a transitions program. You need to understand which patients are going to can be successfully transitioned back to their primary care physician or need to be transitioned to hospice. The average length of stay within your program is 8 months. And you're really, without a letter of approval, you're not supposed to hold on to people for more than 12 months. And so this level of decision-making has to be supported by analytics. You need to be able to use your data, not just to identify folks that would do well with a transfer back to PCP, but you also have, when we say advanced analytics, we've sort of left behind good old-fashioned reporting, which is critically being able to track your performance inside of these contracts to know that you're not doing so great on that transfer. You're actually holding on to patients for an average of 9 months or 10 months. We need to be able to know this month by month so that the clinical teams and the operational teams can react to that and adjust and make sure that they're eligible for that, depending on the program, 30% costs, shared savings, or a 10% bonus or a withhold, or in the case of direct contracting for high needs, up to 50 or even 100% of that finance of your resources are, quote, at risk based on the amount of dollars spent. So this, more than anything, is what's driving advanced analytics and causing organizations to have to pay attention. It's not, as you were saying before, Arif, the question that you had asked Caitlin and others, we've been doing a pretty good job of this as clinicians. Why technology? It's not just to find people that may benefit from palliative care. It's to perform inside of these value-based contracts, which is much more than just prediction. It's really about steering resources to the right place at the right time and adjusting based on what the data is telling you.
I like that, Len, the transition management piece of that. I think it's a really good piece to take away. Jeremy, what can you add to that?
So I think about, I think Len's right. The patterns look promising for there to be a shift in healthcare, but I think the core problem is maybe even bigger than these programs. What these programs have been created to do is to solve the issue we have with healthcare costs in general. We have incentivized certain behaviors that are often perverse for outcomes, meaning they don't provide sort of the outcomes that are expected by the ways things are paid for today. And it's created a problem where 25% of our GDP is on healthcare spend. It's not an efficient system. What we've built is not the right way to build it. Forget the politics of whether it's this nation or some other nation who gets it right. We don't deliver the outcomes for the cost that we have. So these programs, CMMI created most of them, and they've built 44 programs to date. All of them are to solve this problem we have with spend. And what advanced analytics does, whether it's done by CMMI to create these program definitions or to find the opportunity, what the advanced analytics does once they actually come down to market, like VBID for hospice or the primary care for SIP or high needs populations or any other DCE or ACO or whatever it is that's come out of either legislation or this innovation group, what advanced analytics needs to do is to be the cornerstone for how programs can deliver success. And when we think about this in broad strokes, analytics have been around for a long time. Reporting has been around for a long time. It's making those things that exist as evidence to support a better outcome actionable that's the game changer. So if I know for a fact that we can define a definition under Medicare Shared Savings ACOs or under name your favorite value-based contract, if we can define what those contract elements are, there are going to be some portions that are fee-for-service, there are going to be some portions that are value-based and quality payment or total cost of care, the budget that Lynn mentioned. What you have to do is be able to build your machine learning capabilities or your advanced analytics around how do those things, using Caitlin's words, nudge behaviors that would instrument a very different clinical and financial outcome. When you marry those two things together, the best medicine is going to drive the best outcomes clinically. It's also going to drive the best outcomes financially. So CMMI and the legislative branch create these ideas, and then they get pushed down, and they get improved. What advanced analytics will do is whatever the referee says, the rule book says, are the rules for that contract type, you've got to be able to play within them, and that's where advanced analytics can create these insights for behaviors that drive the right kinds of financial and clinical outcomes. And I think that's where you'll see this world really start to take root. I have no interest in doing things as a business owner that doesn't create revenue, that doesn't create a gross margin. I think no part of healthcare wants to do that. That's why you'll see some folks really dig their heels in. I'm already making the monies I need. The gross margins we make are great in parts of my business. But if you look at COVID as just one example and what it's done to primary care, 30 to 50% of revenues are lost because folks are afraid of exposure, contact exposure. If you look at what it's done to hospital systems where the sickest amongst us are taking up beds and electives are turned down, it's going to shift how healthcare gets delivered. These programs applied to this problem around COVID can be the exact perfect scenario, the perfect storm for us to really change what our problem is, which is 25% of our GDP is spent on healthcare and we don't have good outcomes. So I think it's big stuff that we're talking about, very heady, but the reality is this perfect storm has been set up with the Affordable Care Act 11 years ago, with CMMI being created in that time frame, with all these programs having some form of success, and with this opportunity to really take a real swing at the problem that I'm talking about. COVID just adds to that. Anything that's done today with advanced analytics is going to help this part of our economy lift its head up and be able to make big, swift, I think, shifts in the way that things work in the future.
Great. So Caitlin, I'm thinking about a patient I saw in clinic the other day with advanced dementia, and it was her daughter that brought her to see me in palliative care clinic. And, we had a great conversation about sort of planning for the future. And I think a lot about caregivers, and certainly in serious illness conversations, we think a lot about the unpaid caregivers who provide that. They're probably not that interested or nuanced in what type of analytics the healthcare system is using. But can you help me understand sort of what are the tangible benefits to caregivers that we might receive if using these sort of advanced techniques?
Absolutely. So if we take that example of someone with advanced dementia, and we know that there's a high likelihood that person is headed toward a, say, preventable admission, or has a high risk of mortality in a certain amount of time, 12 months, 18 months, what have you. What advanced analytics provides to clinicians is this idea of this patient in front of me, how do I prioritize my time with them today? What are the most important conversations? We know that we don't have enough time with patients. We know that there's a lot of different conversations we need to have with them. And if we have that nudge in the forefront of our minds of, this person's headed for an admission, or this person's headed for, has a high mortality risk, how do I make sure that I carve out time to have a goals of care discussion? The caregiver is with the patient today, the daughter is here. How do I pause and think about, how do I understand this patient and family's goals? And how do I make sure that I'm setting up a care plan that's concordant with those goals? So the benefit to the caregivers then is we can all get sort of lost in the weeds of, here are the medications my loved one is taking, here are the issues I'm dealing with on a day-to-day basis. And we need to take a step back and be able to think about the big picture and whether we're on the course that we want to be on. Are we on the path that we want to be on? What are the most important things to me and to my loved one right now? What's a good day for us? What do we think about quality of life? What are our biggest worries and concerns? And when we have a nudge to say, you know, these patients and families would benefit from that type of conversation today, it helps as clinicians to kind of think, okay, it's breaking me out of automatic mode here. I want to make sure I cover all my bases clinically, yet I also want to make sure I revisit goals of care routinely with these folks. And for caregivers in particular, you mentioned, you know, this huge amount of burden on them, and mostly it's women, it's daughters, it's spouses, it's people who are also taking care of children or other adults at home. They are also often working. So tremendous amount of burden on, you know, an unpaid workforce, essentially, that is doing a ton of work to keep people out of the hospital and to keep people stable and to make sure things don't slip through the cracks. And to Jeremy's point about our, you know, we wouldn't build a healthcare system like we have today. There are a number of ways in which we need to improve, and there are a number of ways in which patients do slip through the cracks and where patient safety issues come to the fore that are completely preventable. So the way that to the extent that advanced analytics can help stave off unnecessary utilization, can help a family visit what their goals are, you know, routinely and, you know, early and often, that it's not some one-time big conversation, but it's something that's just interwoven into the care. To the extent that clinicians get that kind of nudge, we're going to help support these family caregivers because we prevent that admission that was unnecessary, because we help them set up goals, because in those conversations, we understand that they need different supports than they currently have. And we're able to pull in from the interdisciplinary team, a nurse care manager who can follow up the next day when they are home, a social worker who can come and, you know, visit their home and do an assessment and so forth, physical therapy who can come and set things up to make sure their home is safe. So I think while it might feel like a little bit of a stretch about how advanced analytics can help caregivers, I think it's a direct relationship to goal concordant care and ensuring, like I think it was John who said, you know, right care, right patient, right time.
That's great. Okay. Well, I'm going to ask a question to all of you that I think you know will really help us sort of drive home the imperative here. So let me give an example. Let's say you're a health system now, and you're sort of saying, "Yep, we agree. Transition management and patient identification is really important." And we pulled our own data in-house, and we look at patients who have named some bad outcome, hospitalization twice in the last 6 months, and we say, "Well, that's our analytics, right?" So we created a list. You guys create a list. We create a list. We think our list is pretty good. So Len, Jeremy, Caitlin, John, help me understand, what is the imperative to do something different than the in-house list that presumably everybody already has?
Who would you like to go first?
Len, why don't you go first?
Okay. I don't think you should be in the market to buy a list. I think if you're seriously considering either adding to your internal team or partnering with a vendor, it shouldn't be for a better list. It should be because you're now entering into probably a value-based care arrangement that is going to hold you accountable for a number of measures and behaviors that you've not yet been held accountable for. They are going to be using your data to decide whether or not you are successful at meeting the sort of financial and clinical goals that they've set out. So if you're now about to change the way you're getting paid, and a lot of that money is on the line to deliver better care at a lower cost, and you can't use your data to identify the right people, to constantly track whether or not just one doctor, but a whole team of nurses, social workers, and clinicians are getting the right care to the right people at the right time, and that you are performing against these metrics. If you don't have this sort of analytic support to help you perform in these contracts, I think your odds of success in these contracts are decreased substantially. But I think it's important that if your organization is debating one list versus another, you're probably not having the right internal conversation at that time.
It's a great point. Jeremy, what do you add to that?
Yeah, I think your example was a health system. So often health systems are thinking about the problems that they face inside of the four walls, whatever they define their structure as today. And what I think, Lynn brings a point that the contract is one vehicle for them to sort of change the paradigm. We also think the partnerships that are in their community need to be better utilized. So, and when we think about, an organization that's a health system that's made, most of its business around caring for the persons that enter their walls, often through the emergency room or through scheduled events, there are things they have to do really well, regardless of contract, that drive perception, brand recognition, a whole host of other factors that are important to them. And one of those things often is what happens to the familiar faces that seem to show up for lots of the same service, but don't seem to get some version of resolve or resolution from the services being provided. What typically happens when we see is that there are community resources that aren't being well deployed. So if I could, to Caitlin's point earlier, somehow augment these daughters, mothers, the female caregivers that largely burden this unpaid sort of role, if I could augment them with really great community resources, and the hospital itself, the health system you mentioned, could get out of the 30-day readmission penalty or manage transitions better, everybody wins. The patients win, the family wins, the hospital system avoids that readmission penalty. The community hospice or palliative or organization that's providing that service and support for the family members themselves that are providing that care, all of them win. There's not a single point in the system where there's not a benefit, and that's sort of regardless of contract. Because today, even in a fee-for-service world, you're going to have these things that sort of attempt to drive your behaviors to be somewhat different, even if the chassis itself is a fee-for-service complete chassis where DRG is all that matters. And the things you would be looking for are opportunities to make use of service providers that often are so undervalued in a community. And if Caitlin's point, to my belief, is aligned with hers, is that 95% of the care happens for these patients that are this sick inside of the family anyway, why would we not try to better serve all of that need? And I think that's a piece that we would consider bringing to the table. Like, a network of these organizations exists already in your community across the state of North Carolina. It's just that we don't have I can't run a lab test that says this is benign or not, right? I don't get that value for these patients. And we can, with advanced analytics, pretty much promote, hey, these are the kinds of cases that if you do these things, everybody wins. The contracts will come there. They already are there for the readmission. They already are there for high needs populations, DCEs, and Medicare shared savings ACOs. We just don't often work on this part of it because it's a pretty tough place for us to work. And so I think the analytics will take the human part out and make these things happen the way they should have occurred sort of naturally, that they just haven't occurred naturally.
Great, thanks. Caitlin or John, anything to add to that? And then we'll move to sort of an open Q&A.
I think I know we're close to the end of our session. And I think the only thing I would add is that, sorry, just making sure I wasn't muted. I think that when you're thinking about advanced analytics and how it can help you, there's sort of an assessment that has to be undertaken by the appropriate people in your team and in your organization. And it's to ask the questions of what's the goal? What are we trying to achieve? And how can analytics help us get there? And what are the incentives in place? Is it, are we working in mostly a fee-for-service environment? And what incentives and pressures are going to influence that? Are we working in these value-based contracts, which are coming? They are going to be the majority eventually. And And then what's our system of measurement? How do we know our baseline right now? How do we know whether we're improving or where we need some work? And how do we sort of compare ourselves to others and benchmark?
The only thing that I would add to that, and I just a couple of things. We're talking about predictive analytics, right? So we're hoping that we can use this information to accurately predict what's going to happen in the future. And to that end, I think that one of the really big barriers that I see that continues to drive inappropriate use of healthcare resources is that we use the word if instead of when. And I think that we need to be much more focused on this is what is going to happen in the course of this particular patient's trajectory, and knowing that that is the reality. It's not if, it is when it's going to happen. That allows you to help to prepare both within the healthcare environment, but also within the caregiver community as well. And the other thing, just to validate something that Caitlin had mentioned, that I just want to also kind of one of the things that I really focus on is the values orientation of the care that we're giving. Because unless we can really integrate that into the caregiving process, people are going to continue to get things that they don't want and don't need and shouldn't have. So I'll end there.
Great. The separating the ifs and the whens and being clear about which you mean, great point from a good palliative care doc. So I know we've just got a couple minutes left. So is any one or two burning questions, just sort of raise your hand. I'll try to find you. Let's see if people that exist. Well, as people are, oh, okay. Is there Jory Bogat somewhere? All right, Allison could, okay, perfect. Go ahead.
Hi there, sorry, I couldn't unmute before. I'm a pediatric palliative care physician at University of Washington, and I'm just curious what advice folks have for the pediatricians out there and how to get, all this important work that's happening in adult care to also happen for children.
Great question, thank you. Len, you wanna go real quick?
I think I'll pass that to, certainly analytics can be applied. I'm probably not the most qualified person to talk about how to get an organization to invest in pediatric palliative care. I don't know if others on the call would like to take that on to give a better answer.
Well, I don't know how to, I've been involved in some aspect of pediatrics, again, for the better part of 15, 20 years, as part of my practice in the past, setting up programs at a couple of different university hospitals. And the analytics part is difficult because, it's really a pragmatic issue. These are young kids. It's a very diverse audience. We don't have a lot of background understanding information, and we don't have history with these individuals. They develop a serious illness, and now they're on a kind of a USS Enterprise tractor beam. This is what's going to happen. And do we have the analytics capacity to be able to predict what's going to happen? The biggest issue in pediatrics has to do with the ethical construct around what we should and shouldn't do, and the fact that, if I could just summarize it, nobody wants to give up on a kid no matter what the illness is and no matter how severe it is. And so those are the challenges that we face in terms of caring for sick kids and seriously ill kids. And again, I'll just leave it there because we could go on for an hour, Jory, about and you see it firsthand as have I. And these are very, very challenging issues. I don't know that analytics will fix that.
Yeah, I just sort of reflect that it's different, right? So there's a different tolerance for death in the hospital for children and parents. And there's a different sort of, my sense, weighting of a prognosis as sort of being the entry point to particular care delivery models. And obviously a completely different sense of concurrent care that I think adults can learn a lot from, that payment models allow concurrent care for disease-directed treatments alongside palliative and hospice care. So I think there's a lot to learn there. And I think what you're hearing here is that those analytics being iterative as they are means that we'll probably know a lot more in the near-term distant future than we do now. Well, that's a great question. And I think a great way to sort of end the hour. We're at the top of the hour. So let me just share one more slide with you, which is we're looking towards, so first of all, here's my, thanks for you guys attending. Contact information for both groups. There's Jeremy and Len's on the left there. And I imagine if you visit their website, you can also get Caitlin and John's as well. And then on the right is the save the date. So as I mentioned, this is the inaugural roundtable like this. And on January 15th, at the same time, we'll have a discussion about analytics and interoperability and HIEs in particular. And so that'll be a really great conversation. So we appreciate everybody joining today. This is being recorded and it will be shared on the North Carolina Serious Illness Coalition website for people who weren't able to attend. So please do share that with them. Otherwise, we'll see you in mid-January and hope you have a great holiday season. Thanks, everybody.